Thank you for the opportunity. Am I audible?
Yes, sir, you are.
Thank you for the opportunity. I'll be speaking on the use of the modifying your SICS techniques in cases of zonular dehiscence. So let me play the video for you now.
This is an elderly a male patient who is having phacolytic glaucoma with an hypermature Morganian cataract, and that you can see these calcific spots on the anticapsule, all suggestive of a very long-standing cataract, and I expect a very weak capsular bag as well as zonules in this patient. The case is being performed under variable bar anesthesia, and I have created the scleral tunnel, and I'm entering the eye by making these two side port entries. The capsule is stained. OVD is injected into the eye to pressurize it. The scleral tunnel entry is done, and now is the time to perform the capsulotomy. So as expected, once I puncture, there is an egress of liquid cortex out here. So to improve visualization, I'm doing gentle irrigation to ensure that the fluid comes out, and suddenly I can see that the inferior bag just folds up, suggesting that there is a localized area of zonular weakness, and probably vitreous would be trying to come out there. So I blocked that area by using dispersive OVD, which acts like a tamponade and barrier. And I'm now continuing with my rexes. So the plan is to perform initial small rexes, but as I hit these calcific areas, again, it becomes a little bit difficult for me to tear, but nonetheless, I could get hold of a very small rexes. Well, this was the most critical step of the surgery because this gives me an opportunity to place the CTR inside now itself. By putting the CTR inside, it's going to stabilize the bag. Before I do that, again, I fill the bag and inflate it with the cohesive OVD. I'm using sodium hyaluronate that will create space within the bag and push it across. And when I'm trying to insert the ring, it will not cause any stress on the loose bag. So that's the idea of using that viscoelastic. So viscoelastic is holding the bag in place until the CTR is being threaded into it. So once the CTR gets into the bag, now is the time to enlarge the rexes. The challenge is to deal with the part where we have calcification. So I'm making a cut in the opposite quadrant, and then I'm trying to negotiate a rexes by avoiding those specks of calcification. But unfortunately, I hit a roadblock here, wherein as I try to tear the capsule, the bag in that quadrant is threatening to come out. So I stop there, and I have a different technique here. I use a vitrector to cut that area of the capsule, which has got extremely loose zonules. The benefit of using a vitrector is that it cuts the capsule without causing any traction. We can as well use a scissors, but this is my preferred technique. Once the problematic area with the weak zonules is taken care of, the rest of the capsule is dealt in a conventional fashion using scissors and a forceps. Once we have a decent sized opening in the capsule, the nucleus is gently maneuvered out of the bag and removed out of the eye. Gentle irrigation is being done to flush out any remaining cortex. There's hardly any. The bag is now being filled with sodium hyaluronate so that the space is created inside the bag, and then I'm planning to implant the multi-piece lens into the bag. Whenever we have a zonular dehiscence, there is a higher risk of the fluid percolating across it and getting accumulated in the burger space and then causing positive pressure. So that is something like a misdirection syndrome. So the misdirection syndrome is one of the most common reasons why we have positive pressures, especially in such eyes with compromised zonules. So having a good viscoelastic helps here. Once the lens is in place, I'm putting in triamcinolone acetate to rule out any presence of vitreous, which could have migrated across the weak zonules. Seems to be just a little bit there. I'm just doing some anti-vitrectomy. We can clearly see that the triamcinolone acetate has migrated across the zonules into the burger space. It will remain there, no problem at all. final one time, I'm going to recheck for presence of any prolapse vitreous. There is none. Time to close. The conjunctiva is covered back, and I'm using a buried knot of acryl to cover the scleral incision, and that's it. The case was done.
Thank you for the opportunity.
Thank you